refresh. That was a 2011 document. That would only have been significant if that refresh had completely changed the strategy that the entire Western world was following, that was regarded as by the WHO as best in class.
May I pause you there? Is that the 2011 strategy,
Correct.
which in your witness statement you state that for the purposes of pandemic planning was woefully inadequate?
Woefully inadequate. And I don't think a refresh would have changed that, because all of the independent external advice, the World Health Organization advice, indeed the international health regulations, stated that we should not have lockdowns. In fact, in a 2017 document, it said the evidence is not strong enough to warrant advocating legislative restrictions. This is where I need to add to what I've written in my written statement, because I thought at the time it was simply an oversight not to consider lockdowns. Actually, it was an explicit decision. The London Resilience Partnership published document, May 2018, and I quote, "It will not be possible to halt the spread of a new pandemic." That was the attitude, it was the doctrine, and it was wrong. So that refresh would have made very little difference. Healthcare surge was largely complete. The final action there is on involvement of the DAs. Since healthcare is devolved, that would have been not been a terribly important area. Adult social care largely complete. I'm not exactly sure what the CMO actions outstanding are. There's a question. My point is about materiality.
May I just pause you there to ask you some more questions about adult social care, since you raise it?
Yes.
In your statement, you refer to the fact that one of the major problems with the department's supervision of the adult social care sector was the lack of policy levers.
Yes.
Which would enable the department to ensure pandemic preparedness in social care.
Yes.
And as you said earlier...
But that's not what this is referring to.
Well, I want to ask you whether or not you can say that the adult social care sector was well prepared for a pandemic when the department had no means of finding out whether or not they had the right plans in place, whether local authorities had planned sufficiently, let alone how many numbers were in the care sector.
No, it was terrible.
The department had no visibility of whether or not the adult social care sector was prepared at all. It wasn't within your ability.
That's not my contention. My contention is this action here would not have solved that. The CMO could not have solved the problems in terms of oversight of the adult social care sector.
Mr.
It was
Hancock,
much bigger than that.
What was the name of your department?
I've already talked about this. It's the Department of Health and Social Care, and yet the legal responsibilities are with local authorities. And we had a separate program of work underway that did not stop because of Brexit planning, that was accelerated by the new Prime Minister in summer 2019, of reform of adult social care. We had ongoing work to get better data that was continued in this process. Adult social care desperately needs reform. It needs more support, it needs more resilience, and I feel that very strongly, as does the current Chancellor of the Exchequer, who has been clear about that, not only when he was in my job, but in his current job. My point and my contention is that whatever the CMO actions outstanding were here, they would not have solved the huge challenges of adult social care in this country, which requires significant improvement and work.
By January 20, did the department have in place, the Department of Social Care have in place, a single coherent plan to identify vulnerable service users across the country? That is to say, how many people are in the care sector?
No.
Did it have a central plan for the sharing of data between private and public care providers and emergency responders in order to be able to better prepare them all for a pandemic?
Something along those lines was being developed, but it was definitely not in place.
Was there a single national guidance for pandemic preparedness in the adult social care sector?
The guidance for pandemic preparedness went through local authorities, and so there was not a single one, no.
Did all the LRFs, the local resilience forums, have plans in place on the local authority level for dealing with the impact of a catastrophic pandemic on the elderly?
No, they were required to, and as far as I'm aware, only 2 had done the work.
Was the Department of Health and Social Care able to verify the extent of the pandemic preparedness planning that was being done by local authorities?
No, we didn't have the policy levers to do so, despite having the name social care in the title.
Did the Department of Social Care put into place a national standard by which the plans from the local authority could be gauged?
Nope.
At the latter end of 2019, which for the very first time obliged local resilience forums to compare their plans against a national standard for influenza pandemic planning?
Well, yes is the answer.
It is.
And I suppose what that demonstrates, because that came into place late in 2019,
Yes, indeed.
is my
December.
central contention in this area, which is that the system for how we run adult social care is flawed. There was work ongoing to try to resolve it, including work directly related to pandemic planning, but it was in nowhere near good enough shape, and it meant that as the person trying to solve this problem with a disease that self-evidently impacted on older people most, we were in an incredibly difficult position to do so when the pandemic struck. And despite the enormous hard work of everybody in that sector and in the department in relation to adult social care, it was very, very difficult early on. And that's been in part because this planning was ongoing, but the systems in this country for managing adult social care are not good enough. And that reform work was underway, but it still hasn't been completed.
So drawing some of these threads together, please, Mr. Hancock, would you accept the following propositions? Firstly, there was a long-standing bias within the Department of Health and Social Care as the risk owner of the pandemic influenza risk and as the author of that strategy, which you described as woefully inadequate, in favour of influenza, a failure to pay sufficient regard to the risk, admittedly a lesser risk, of another different catastrophic HCID.
It would have been better, yes, if the plans had been for a generic respiratory disease, because what matters is the characteristic of the novel virus.
Indeed. Proposition 2, there was a failure to think through properly the risks of a non-influenza pandemic due to the inherent unpredictability of viral respiratory pathogens and their characteristics, as you say, transmission rate, high or stuttering, incubation period, long or short, viral loads, great or less, whether viruses congregate in the upper or lower respiratory tract, whatever they may have been, because those other characteristics were simply not thought about enough, the real risk of an HCID with catastrophic consequences was not adequately thought about either.
I wouldn't put it like that, and I think there's an irony here. The irony is that one of the major problems we had early on, which I'm sure we'll come to in M2, was the fact that COVID-19 has asymptomatic transmission. It's the first known coronavirus that affects humans that can be transmitted asymptomatically, and the WHO assumption was that this wasn't possible until April 2020. There's a really important reason I'm saying this. A flu plan assumes asymptomatic transmission.
Indeed.
There are some ways in which the flu plan was in fact more appropriate as a planning document than a generic document, or indeed a document that had been written to consider the impact of one of the then known coronaviruses, because that plan, a coronavirus pandemic plan, would have assumed no asymptomatic transmission. So this underpins my point that, of course, it would have been better to plan for a generic, respiratory disease X, and that is what we should do in future. However, planning for flu did have some benefits, and it brings me back to my central contention that whilst this was an error, it was in no way the biggest error. And it's not just that there were 2 errors in the core plan, flu rather than coronavirus, and wrong doctrine. The error of the flawed doctrine was significantly bigger than the error of targeting a flu rather than a coronavirus pandemic.
All right. Well, I don't need to trouble you about degrees of failure. We'll come on to identifying the various propositions.
Yeah.
The third issue is one you've just touched upon, which is that approach in the risk assessment was cause agnostic. It simply failed to identify a sufficiently broad range of scenarios. And as you know, the risk assessment process has been rewritten, thanks in the main to a report from the Royal Academy of Engineering.
Yes.
To make that claim.
Yes, and there's an irony there as well, which is that we were dealing with a live Ebola epidemic, with the potential threat that would come to this country as a pandemic, and yet at the same time the paperwork was all focused on a flu pandemic.
Yes.
So the theory written down in these strategies was actually not what was playing out in the day-to-day practice of infectious disease management that we were undertaking as a department and that PHE was undertaking.
But Mr. Hancock, it's not just a question of irony, is it? These failings materially hampered the United Kingdom's ability to prevent death.
The central failing that hampered the UK's response, common with the rest of the Western world, was the refusal and the explicit decision that it would not be possible to halt the spread of a new pandemic. That is wrong, and that is at the centre of the failure of preparation. I know that because I was the person responsible as the Category 1 responder when this pandemic struck, and all of the other considerations are small, important but small compared to the colossal scale of failure in the assumption that it will not be possible, and the lack of ambition in the assumption that you can't stop the spread of a disease. We can. Imagine if this disease had tragically killed children as much as it did old people, and maybe it transmitted twice as easily as COVID. Would it then be possible to stop this halt the spread? Of course it would. We would do whatever it took, and that's where we got to. But we got there far too slowly because none of the preparation included any thinking around that.
And that is my fourth proposition. It's the one that finds a place at the front of your witness statement. It is that there was a failure, a complete systemic failure, to think about how to prevent catastrophic consequences arising at all, as opposed to how to manage catastrophic consequences which were assumed to result.
I couldn't agree more, and it's an absolute tragedy.
Number 5, there was an associated failure to think about countermeasures, because, of course, flu has a shorter incubation period, it is symptomatic, there are antivirals, there are vaccines available. There was, therefore, a failure to think about, in the way that other countries, particularly in the Far East, had done, countermeasures such as mandatory quarantines,
yes,
shielding,
yeah,
social restrictions,
yes,
border controls.
yes.
There was, as you say, a complete lack of imagination.
Yes. I had to overrule the initial advice not to quarantine people being brought back from Wuhan. I mean, it's madness. And it was written into the international health regulations that you shouldn't close borders. This was not a UK problem. It was a World Health Organization problem. And the World Health Organization, of all people, should have learned the lessons from MERS and SARS. And so we had diligent, hard-working teams working on this pandemic preparedness, but there was a absolutely central doctrinal failure in the response of the UK and almost every other Western country.
And number 6, coming to the government particularly through the Cabinet Office and the DHSE, there was a failure to implement, in a general sense, the recommendations from the various earlier exercises because the majority of them were simply not implemented for good or ill by the time the pandemic struck, and actions and work streams which were identified as being necessary in the field of pandemic preparedness were not carried through to fruition.
Well, while that is true, my evidence to you is on materiality of what really mattered when the pandemic struck. And as we saw when we went through that list on the screen, those work streams that were stopped, I couldn't identify any of them that would have made a material impact had another year's work been done on them. We got halfway through them, and what I put that down to is the team prioritising within the resources that were available to do the things that really mattered. And the thing that was most useful to me when the pandemic struck was making sure we had a piece of legislation ready to get onto the statute book. Now, there's a lesson there as well, which is we need a new piece of legislation, both for civil contingencies, and we need an update to the 1984 Public Health Act. And I'm very happy to give further evidence on what's needed there. But my point is that I think the team were working very hard to try to do the things that were the most material in terms of preparation. What everybody missed in the Western world was that lockdowns were going to be necessary, and that's why I'm stressing this point so much, because it is the single most important thing we can learn as a country.
Mr. Hancock, you've just said I couldn't identify any of those work streams that would have made a material impact. Was not one of the work streams the need to identify data, numbers, the planning for the number of people in the adult social care sector who would be affected by a pandemic, and the planning for the required surge capacity which would be required in the event of a pandemic? Are you saying those?
My recollection is that data work continued as part of the adult social care reform plans.
Did that work get completed by the time of the pandemic?
It didn't get completed, but the work continued.
Was a fully developed plan for surge capacity in the adult social care sector put into place by the 1st of January 2020?
A fully developed plan, no. Your question originally, to which I responded, was what the work being done, but it hadn't been completed, no. There's a difference between doing work and completing work.
There is a difference between planning something and not even completing the plan so that the work can't be done. Was the planning complete to allow the surge capacity to be developed?
I'm very happy to look further into the paperwork and write to you on that point. My point was a more strategic one about what really matters in terms of protecting lives in the future, and that's why I'm at so much pains to stress it.
There were significant areas of preparation overlooked or not progressed. Would you agree?
Absolutely.
Were the nation's preparations for a pandemic of this nature good enough?
No.
Was there a serious and significant inadequacy of preparation for a pandemic health emergency?
Yes.
Preparing for this Tier 1 risk of a catastrophic health emergency was at the core of your own department's functions. Would you agree?
Yes.
And therefore, as Secretary of State, you bore and you bear ministerial responsibility for that calamitous state of affairs, do you not?
I bear responsibility for all the things that happened, not only in my department, but also the agencies that reported to me as Secretary of State.
You will no doubt have given a great deal of thought, and it's evident from your evidence today, Mr. Hancock, as to how to make things better.
Yes.
And you've mentioned many of them today in the course of evidence. Are you aware of some of the matters that Sir Oliver Letwin spoke about when he gave evidence? Do you agree that there is now a need for a formal system of training for ministers and senior civil servants in civil contingencies?
Yes, there's an irony here, another one, which is that I was in the process of putting one in place with the Blavatnik School of Government when the pandemic struck, and we stopped that work because the pandemic became overwhelming.
Is there a case for a cabinet minister to be appointed to be in sole charge of EPRR?
Yes, across government, and then the responsibilities of lead government departments would need to report into that minister, who would then act on behalf of the Prime Minister. That's effectively the job that Oliver Letwin did when he was in office.
And therefore there needs to be a head of resilience at the apex of an official structure, a civil servant, who will then report to that cabinet minister.
Yes, there's one subtlety that's incredibly important here, which is that it would be a mistake if such a structure took away the sense and the feeling of accountability for an individual department. What you wouldn't want is the department thinking, oh, well, the Cabinet Office has got that covered. You need the department to still feel that it is accountable and held to account by the Cabinet Office rather than replaced by the Cabinet Office, which would be suboptimal.
So I'm not following. What he's suggesting would be different from the present system, Mr. Hancock?
That you would have, as we had when Oliver Letwin was in post, a minister responsible for resilience across the board and for challenging the different resilience plans that came up. And obviously that will require an official structure underneath her or him. And but the key point is that needs to be like a red team effort, as has been discussed, rather than letting the departments off the hook for the areas which they're responsible.
And would you have that minister solely responsible for resilience? I've heard that Cabinet Office ministers get quite a large portfolio on occasions.
Yes, I think whether or not they attended Cabinet, what mattered actually is in practice whether they had the ear of the Prime Minister. You could easily make it the person who was in my old Cabinet Office job as number 2, so long as they had a direct line to the Prime Minister when it mattered.
Is there now a case for an independent, perhaps statutory resilience academy or some such body to warn, advise, guide in relation to EPRR, train, organise exercises and make sure that recommendations and actions are properly implemented?
Yes, I think there's value to that. Again, you wouldn't want to take away from the individual responsibility of the area concerned. Let me give you an example. We now, once again, have a body whose sole responsibility is preparing Britain to be resilient to external health threats, UXA, and Dame Jenny Harries is an excellent chief executive of UXA. You wouldn't want such a body to replace UXA or make UXA feel less accountable. I want Jenny Harries and whoever's in her job to wake up every morning worrying about the next pandemic and what needs to be put in place. You can, of course, supplement that with better resilience training at the centre as well, but you mustn't take away from the real burning accountability of the person in that job. And also, one of the recommendations was that these people would make recommendations in terms of allocation of budget, because there's obviously been a discussion of the impact of budgets in the last couple of weeks. It isn't just about the total quantum of budget, it's about how it's spent. In this country, this year, we spent £53 billion on physical military defence. UXA's core budget is £450 million, that's less than 1%, and yet over 220,000 people have died of COVID so far. The impact on the health of the nation and the well-being of the nation of health protection is an order of magnitude bigger than as currently represented in the UXA budget. And the idea that we spend over £50 billion on defence and under 500 million on UXA is, for me, completely indefensible.
All right. I was asking you, in fact, about a general resilience academy to deal with civil contingencies. You responded by reference to the United Kingdom Health Security Agency. That is, of course, involved with health emergencies,
exactly,
as were you.
So it's worth having across the board as well.
Yes. I intended to ask you, and I perhaps didn't make it sufficiently plain, whether there is a case for Resilience Academy to deal with civil contingencies, for example, a collapse in critical national infrastructure or a cyber attack or some other mass event or catastrophe which could befall our nation. now beyond time, is it not?
It is beyond time. The reason I got into budgets is that it's only a central body that can also make recommendations in terms of allocation between different departments. As a departmental head, you can't do that.
Yes. Is there therefore also a case for fundamental rethink on this whole CCA 2004 structure and the lead government department model? I don't want to intrude into Module 2 issues.
Sure.
But obviously, when dealing with a national crisis,
Yes.
it's beyond the ability of a single department to be able to cope, because, of course, all national crises, by definition, will have an impact, a range of impacts across government.
Yes. I think that you need... I actually support the lead government department structure, because you need somebody who feels accountable for looking out for that threat all of the time. But you then need a system in the centre that is stronger at holding that accountability, holding feet to the fire, but the coordination element of it, when you get to a massive crisis, goes up to the chain to the Prime Minister anyway, and so that is a role of the Civil Contingencies Secretariat, which, when you have a huge crisis like COVID, then was replaced with a COVID-specific central secretariat.
But some of these issues, Mr. Hancock, didn't go to you, even though you were the Secretary of State in your own lead government department.
Yes, but imagine...
So with respect, is there not now a need for a much stronger coordinating body, not perhaps just part of the Cabinet Office, but a stronger body which can ensure that in the run-up to a crisis, in terms of the preparation, the preparedness, the planning, things that need to be elevated to the highest levels are?
Yes. The way that I put it is that the goal of it should be to hold the lead department's feet to the fire. For instance, if you had one of these bodies in the centre, if they tried to do the job of the Health Secretary as the Category 1 responder, then who guards the guardian? Far better would be that they are in a position to haul in the Health Secretary and say, are you doing that enough? Because I wasn't called to the National Security Council, for instance, in order to answer those questions in my 18 months as Health Secretary before the pandemic struck.
Finally, I want to ask you some questions, please, about some other aspects of the system which you found to be deficient when you were faced with a terrible crisis in January of 2020.
Yeah.
You've touched on many of them already, but I just want to summarise the position in order to be able to focus minds for when we get to the next module and thereafter.
Yes.
The areas that require particular and detailed consideration.
Yeah.
There was obviously this issue, therefore, of there being a stockpile of PPE, but as it happened, given the sheer number of casualties and those who were sick and ill, and of course those who died, the stockpile was depleted, sorry.
Yes.
And it was necessary for the government to try to secure further supplies through just-in-case contracts and deal with the mayhem of the international markets.
Yes.
Is there therefore an issue which requires further consideration in relation to how we make sure that next time such stocks as there are, such stockpiles as there are for the particular pandemic which may eventuate, are sufficient, or at least that there is an ability to improve the numbers, to increase the numbers,
yes,
in a way that doesn't leave the Secretary of State as you were having to make up the deficit?
So we started buying PPE in January 2020, long before it was certain this would become a global pandemic. But the problems with the stockpile were very significant, and I'm sure that we'll come to this in future modules. What is vital for preparation is that there are stockpiles that are accessible, pickable in the technical language, that can be distributed quickly and can be distributed to all health and social care settings. And as I say, I think there should be a legal requirement on health and social care settings to hold a significant amount of PPE to be able to get through the early weeks of a future pandemic, because the sheer logistical complexity of setting up these supply chains in short order is exceptionally difficult, as we learned.
All right. I don't want to ask you to address the solutions, or in fact to identify the specific problems that arose, only to acknowledge that there were very real difficulties in these areas. The availability of mass diagnostic testing,
yes,
you've already referred to.
Terrible.
The availability of mass contact tracing systems.
Yes, there was no such thing.
Obviously, there are the NHS-related issues concerning resilience, bed capacity, workforce planning, all of which are issues which you've referred to.
Yes, there's a bigger thing there as well within the NHS, which is that, whilst the discussion on how much resources the NHS should get is a highly political one, and we've seen it play out over the last couple of weeks in this inquiry, there is actually a really big question that the nation needs to ask itself, which is that you wouldn't ever send the whole of your army out into battle at once. You have spare capacity in case there's a crisis. You have what they call redundancy in the military sense. Yet every single day we send our whole army of the NHS out into the field, and there is no redundancy. We run the NHS incredibly tight. It's an incredibly efficient organisation in the grand scheme of things, despite obvious areas that can be improved. It is overall run very tight, and that means that there simply isn't the resilience when a crisis comes. But that would require a materially huge increase in the already very, very large NHS budget. But other countries choose to spend a higher proportion of GDP on healthcare and have that redundancy. And it means that they are better able to respond. But it also comes back to doctrine, because no health system of any size would be able to respond unless you suppress a virus when it's as bad as COVID-19.
But as Milady has already observed in another context, there are choices that will have to be made, and there is therefore an issue about resilience and about bed capacity and surge capacity and so on.
Absolutely.
For the future.
Absolutely.
All right. And then in your statement, you address issues such as the changes over time in the public health structures.
Yes.
There is an issue about the necessary degree of coordination across the United Kingdom, given the fact that health security is a devolved issue.
Yes.
But at the same time, of course, viruses honour no boundaries. And then finally, you say that...
Well, they honour geographic boundaries. They honour no administrative boundaries.
Right.
The fact that we are an island is an advantage that we should use much more aggressively in future in preventing a pandemic coming here.
And you refer finally to the need to examine more closely the degree of required international coordination.
Yes. I
don't want you to develop that point. There remains the final issue, which I think I'd be grateful for your views on, which is the degree to which you materially assisted in the development of what turned out to be life-saving vaccine production.
Yes.
We heard evidence from Jeremy Hunt MP as to how he assisted to the process of the UK vaccine network when he was Secretary of State. Were you also materially concerned in ensuring that we had the proper structures in place for future development of vaccines when you were Secretary of State?
Yes, I thought this was very important. And in fact, in terms of pandemic preparedness, given the reassurances that we were well prepared, this was the area I put most effort into. And a lot of the preparedness work was very helpful here. The Oxford vaccine was essentially built on a project that started with an attempt to get a vaccine for Ebola. That was before my time. I worked to try to enhance the domestic manufacturing capability, and I did a huge amount of work also on stopping anti-vax content. I was worried about that for normal everyday vaccines like MMR and the flu jab, but it was also very important ahead of a pandemic, because the point is that once you have the right doctrine of suppressing a virus until the vaccine can make us safe, you've got to make sure that you get the vaccines and that people have the confidence to take them. So there was a huge amount of preparation work in that area that I was directly involved in, and that ended up being one of the areas where we performed incredibly well, and we of course had the first vaccine in the world.
And Mr. Hancock, my final question: do you know why no pathogenic outbreak-related exercise or any governmental policy or guidance or paper paid any regard to the impact or consequences of a pandemic on the vulnerable, on members of our community in our minority ethnic sectors, or on the marginalised or otherwise suffering from inequalities? There appears to have been absolutely no thought given at all at any time, other than in relation to the obvious point that there would be a clinical risk, to what the likely impact would be of a pandemic sectorally. And therefore, no thought was given to how the plans might be adjusted to cater for that significant risk.
It saddens me enormously that the central work that the CMO was planning to do when I appointed him in October 2019 was to focus on the reduction of the completely unacceptable health inequalities that exist in this country. The life expectancy of a man born in Blackpool is 15 years less than a man born in Buckinghamshire. And I appointed Chris Whitty to the CMO job based on his proposal that he wanted to do everything that we could to address this. So health inequalities were right at the forefront of his and my agenda. Of course, the different impact clinically of a virus on different groups is absolutely front of mind and implicit in all of the planning.
Well, that's obvious.
It has to be. But in terms of the social and socio-economic impacts, all I would say is that an assumption that you're not going to stop a pandemic running through the population is, but implicitly, an assumption and a decision that those most vulnerable to it will be hardest hit. So the single best thing we can do to protect those who are most vulnerable is stop viruses from killing hundreds of thousands of people. And it brings me, we end on my central contention, which is you've got to work out, there are costs of lockdown, you've got to work out whether the impact of the virus is going to be worse than the costs of lockdown. And if it is going to be worse, as was the case with COVID-19, you've got to hit it hard and very, very early.
But, Mr. Hancock, as you now have acknowledged, our system of preparedness for being able to deal with the pandemic was materially hindered and weakened, and the sad reality is that as part of that failure, there was no consideration of the needs of the most vulnerable at all.
There was consideration on a clinical basis of the needs of the most vulnerable, but not on a socio-economic basis. And if I may add finally, this was, of course, an unprecedented pandemic in anybody's lifetime. And those who worked so hard to respond to it had to respond from the basis of the preparation that there was. And they did work incredibly hard. And I think everybody in the health area that I was responsible for gave their all with humility in the face of this virus and unprecedented event. But that just underlines why it's so important that we get the right lessons out of this inquiry.
The lions led by structural donkeys, Mr. Hancock. Personally, everyone gave their all, but the system was not fit for purpose, was it?
That's absolutely right, and it goes. Was a problem across the Western world, and it goes back a long, long way in the assumptions underpinning how we plan for these things, and it must never happen again.
My lady, that concludes my questioning, Mr. Hancock. There is one area submitted by COVID-19 Bereaved Families for Justice UK and Northern Ireland COVID-19 Bereaved Families for Justice, for which you've given permission.
Mr. Weatherby, sorry, not quite finished, Mr. Hancock.
No problem.
Yes, thank you very much. Mr. Hancock, I ask you a few questions on behalf of the COVID Bereaved Families for Justice, which represents the interests of many, many bereaved families from across the United Kingdom. And it's centred around the pandemic flu bill, which was one of the two key work streams that were kept going when most of the rest of the refresh, as we've heard it called, was paused because of Brexit. Is that right? So that gives the importance with which you looked at the pandemic flu bill. And the
yes, and I would say it was one of the most important things to come out of Operation Cygnus.
Okay. I want to just explore the background of that and what was in it very, very briefly indeed. Yes. But you have already indicated to Mr. Keith that the 2011 doctrine strategy was woefully inadequate.
Yes.
And you put that in your statement.
Yes.
And I just want to just read that one paragraph from your statement to flesh that out.
Yes.
Clearly, this is your words, clearly the approach in the 2011 strategy was woefully inadequate. I have no idea why the 2011 strategy did not consider the approach taken by countries affected by SARS and learn the lessons for the UK. I also do not know why the WHO considered the UK one of the best prepared countries in the world, when our strategic approach did not consider it possible to take social distancing measures necessary to stop the spread of a killer disease.
Yes.
Yes. And so you're emphasising the lack of learning and the emphasis around social distancing measures.
Yes.
And that would, of course, include lockdowns.
Absolutely.
Yeah, okay. And you've also elsewhere, paragraph 29, referred to the WHO as an authoritative source.
Yes.
So you're giving respect to the view of the WHO, yes?
Well, it is the UN agency in this area. It
Indeed.
needs radical reform, but nevertheless, it is what
we'll
it is.
leave that one for a different day, but
right.
You were regarding that as an authoritative source. In 2018, at precisely the time that this work on the pandemic flu bill was being completed or being looked at, considered, the WHO, as part of its global influenza programme, published an update to a document which had been around since 2005, entitled A Checklist for Pandemic Influenza Risk and Impact Management.
Right.
I just want to take you to one passage of that.
Okay.
And it's 187748, please. And page 1. Have you got it in front of you there?
I've got the title screen, but not the paragraph.
No. Just want to orientate us all. This is the WHO document, 2018. I'm going to take you to page 11 in a minute. In the interests of time, I'm just going to flag up one other reference, which is at page 6, where this document refers to the importance of prevention and mitigation and not simply response and recovery.
Right.
So by 2018, the WHO are putting out guidance which underlines the necessity of prevention and mitigation and not just response and recovery, which I think is one of your points, isn't it? As one of the problems with the UK's doctrine.
Well, I haven't seen this document. It depends what you mean by prevention and mitigation, because the initial containment and an attempt to contain the virus was part of the UK's plans. The problem with the UK plan was that once we got to community transmission, it was wrongly assumed it wasn't possible to stop the spread.
Yeah, okay.
Mitigation in this context tends to mean dealing with the consequences, which is not good enough.
Well, that, with respect, is response rather than mitigation.
Well, I'd be very happy to read the document and consider it.
Well, okay. Can I take you to page 11, please? And we will just have a quick look at this, because this is the important passage of it with respect to the pandemic flu bill. It hasn't come up in front of me. Yes, it has. So this is paragraph 2.2 within this document, and it's headed Legal and Policy Issues, which is why it's relevant to what I'm asking about with the bill.
Yeah.
So the rationale, the public health measures during a pandemic are designed to reduce the spread of the pandemic virus and save lives. In some circumstances, it may be necessary to overrule existing laws or individual human rights in order to implement measures that are in the best interests of community health. And then I'll skip the next sentence again in the interests of time. At the end of that paragraph, these decisions need a legal framework to ensure transparent assessment and authority for the measures being considered, as well as coherence with relevant international laws.
Yes.
So here's the WHO saying that you need to consider the measures, and then you need to have the legal backing in place before the problem strikes. Yes? Next part. This document splits the guidance into essential, what the WHO regards as essential, and what is desirable.
Yeah.
This is under essential. And then the first bullet point, review existing legislation, policies, or other government instruments relevant to pandemic influenza risk management, and etc. Yes?
Yes.
And that's what you're doing in around 2018 with the pandemic flu bill.
Yes.
And then the second bullet point.
Yeah, all that.
And this is the important
That was
point.
all in the,
Yeah. Assess the legal basis for all public health measures that are likely to be proposed during a pandemic response, such as isolation or quarantine of infected individuals, people suspected of being infected, or people from areas where pandemic influenza infection is established. So a legal measure in place for an emergency to restrict the ordinary rights of people who are infected or may be infected, yes?
Yes.
Second bullet point, travel or movement restrictions, i.e. on leaving or entering areas where pandemic influenza infection is established. So travel and movement would include lockdowns.
Yeah.
Closure of educational institutions.
Yeah.
And prohibition of mass gatherings.
Yeah.
Yeah? Okay. So all relatively straightforward in concept.
Just one point I would challenge, which is you said travel or movement restrictions, that means lockdown. That's not right.
No.
What it doesn't have in there is a stay-at-home order, because the isolation or quarantine of infected individuals is for, as it says, infected individuals.
Okay. I said would include lockdowns. In parentheses, that is on leaving or entering areas where
a lockdown is where people are required by law to stay at home, which is different.
I'm not going to fence with you over that one.
No, but it really matters, because if the question is, given that the WHO published this in 2018, why didn't we have it in place, right? If that's the question, the pandemic flu draft bill, which became the Coronavirus Act, and the Public Health Act 1984 has the legal framework for all of this in it. However, the review compliance with obligations under IHR sentence in the top bullet point, that IHR includes the rule that you should not close your borders in a pandemic. And the fact that the second bullet point does not include a stay-at-home order precisely supports my point that there was not consideration given, even at the WHO level, to the requirement for lockdown.
Okay,
because a travel restriction is not a lockdown.
Okay, I haven't got the time to go into the international health regulations with you. We can perhaps deal with that in a different way.
Sure.
But here you have a list of straightforward, sensible options which the WHO reference to the spread of the pandemic or stopping the spread of the pandemic.
Yes.
And there are options which are likely to be proposed in an emergency situation such as a pandemic. Yes?
That's what it said. That wasn't the policy of the UK at the time.
It wasn't the policy of the UK at the time, indeed. Because we get to the pandemic flu bill, and in light of what you've just said, I think we will need to put it up, just the contents page. And it's 23118, please. So this is the bill as drafted, dated 2020, in fact. So this is after the work presumably is completed. And what we see here is the bill has clauses which relate to the emergency registration of health professionals.
Yes.
A raft of provisions dealing with the easing of ordinary business as usual duties within the mental health system and the health system, and an indemnity in terms of healthcare.
Yeah.
Now, which of that list that we've just looked at from the WHO guidance, which of that list is in this pandemic flu bill, Mr. Hancock?
I don't know, but I do know that of that list in the WHO guidance, many of those are in the Public Health Act 1984, because it was the Public Health Act 1984 that we used as the legal basis for restrictions.
Yeah. So, in fact, it's clause 14 is the temporary closure of educational institutions. So the only one of that list that's made its way into this bill is the restriction or temporary closure of educational facilities.
Right.
So you've referred to other acts, but this is the work stream which is refreshing or supposed to be refreshing or updating the doctrine. And this is the bill which is supposed to be there to give you an armoury in an emergency situation. And it doesn't follow this authoritative source from the WHO. How was that allowed to happen?
Because the other recommendations from the WHO were already in law in this country, in the Public Health Act 1984. If I may say so, I essentially think that the core point you're making, which is that we should have been ready and had legal powers in place, and we should be ready to lock down, that I agree with wholeheartedly. And I agree with it, and I think that, to do justice, as much, nothing can bring the people who died back, and each and every one. But we must learn that lesson, that we need to take the measures necessary early to stop a future pandemic from killing people.
Yes.
But to say they're not in this bill, and it without considering what other bills they might already be, doesn't really prove that point.
Okay, well, I'm sure we can look at other legislation as we go along, but this is the work stream.
I know, but I used that legislation extensively. I understand that the Public Health Act 1984 very well, and what I can tell you is that the WHO recommendations in 2018, other than on temporary closure of educational institutions, those powers are available, as far as I understand it, in the Public Health Act already.
Finally, just in terms of the devolved nations, it's right, isn't it, that this legislation was developed, this draft legislation was developed with some input from the devolved nations.
Yes.
It's also right that none of them used it in the event.
Because they had their own other legislation already on the statute book. Yes. I mean, I actually think that we could do... part of the reason for a need to reform the 1984 Act is to have a UK-wide approach, because I think that whilst it's totally appropriate to devolve health and the NHS, because of the nature of how pandemics spread, it would be far better to respond to the next pandemic on a UK-wide basis rather than an England, Scotland, Wales and Northern Ireland basis. And I think that way we would save more lives.
Yes. Finally, are you able to point to any document or any briefing or any meeting where the fact of powers or legislation being elsewhere was a factor in what was included in this draft bill?
Oh, yes, of course. That was the important consideration in what to put into the bill, because one of the things that Parliamentary Council who draft bills absolutely hate is legislating in an area where a policy is already legislated for.
Yes, okay.
So that is a material consideration, yes.
That's all I asked. Thank you.
Thank you.
My lady, we've received an email from bereaved families of Justice Cymru who wish, I think, perhaps vicariously, to ask for permission for a point to be put to Mr. Hancock, who said in the course of his evidence that coronavirus was the first coronavirus known to be, or the first coronavirus that could be transmitted asymptomatically. The position is, as the chart that you directed be prepared amply demonstrates, is that MERS and SARS are also asymptomatically transmitted, and therefore there is clear evidence to correct that position. I don't want to give evidence about it, but there is that material there in the chart. But perhaps I could be permitted to ask you one question, Mr. Hancock, in light of the question from bereaved families of Justice Cymru. The transmission rates in relation to MERS and SARS-1
Yes.
are, of course, very different to COVID.
Yes, yes. What I stated was the clinical fact, as I was advised during the debate about asymptomatic transmission, which no doubt we'll cover in M2 because it was absolutely central to the challenges of the early response to the pandemic.
Thank you. Melody, that concludes Mr. Hancock's evidence.
Thank you very much, Mr. Hancock. That completes the evidence you'll be giving, certainly in this module. Thank you for your help.
Okay, thank you.
2 o'clock.
All right.
Good afternoon, my lady. The next witness is Mr. Duncan Selbie, who is appearing this afternoon at the inquiry through a link from the Kingdom of Saudi Arabia. I hope, my lady, that you can see Mr. Selbie on your screen.
I can, thank you.
Mr. Selbie, would you please take the affirmation?
Yes, good afternoon, everyone. I do solemnly, sincerely, and truly declare and affirm that the evidence I shall give shall be the truth, the whole truth, and nothing but the truth.
Thank you. Mr. Selbie, thank you for the assistance that you've given to the inquiry so far. You have provided a witness statement, which we can see at 192268. Now, that's appearing on my screen. Is it also appearing on your screen?
Yes, it is now. It's rather small, but yes.
All right. It's being enlarged. Yes. Is that helping at all?
Yes, that's better.
Excellent. All right. Well, whenever I show a document to you, I'll make sure that the document presenter makes it as large as possible for you. Can you confirm, please, Mr. Selbie, that that is your witness statement?
Yes.
Thank you. We perhaps don't need to go to it, but it is signed at page 14. And is that statement, Mr. Selbie, true to the best of your knowledge and belief?
Yes, it is.
Thank you very much. We can take that down. I will ask you questions, and I hope that all of them are clear and that you understand them. If you don't, then please just let me know, and I will ask it again or try and rephrase it. If you need a break at any time, Mr. Selbie, please just let us know and we will break for your convenience. And please keep your voice as loud as you can so that the stenographer can hear you for the transcript. Can you also confirm, please, Mr. Selbie, that you have read the witness statements provided to the inquiry by Professor Dame Jenny Harris and also Professor Isabel Oliver?
Yes, Ms. Black, but I'm terribly sorry. There was interruption for about 3 seconds. I hope this isn't going to happen.
Well, so do I.
Could you repeat the question, please?
Yes, of course. I was asking Mr. Selbie if you can confirm that you've read the witness statements of Professor Dame Jenny Harris and Professor Isabel Oliver on behalf of the UK HSA.
Yes, I have.
Thank you very much. And do you broadly agree with what has been set out in those witness statements so far as Public Health England is concerned?
Yes.
Thank you. I want to begin by setting out your professional background and qualifications so far as they're relevant to this inquiry. You have qualifications in health and hospital management and health and social care management. You held various NHS posts in Scotland and London between 1980 and 1986. Then in 1997, you became Chief Executive of South West London and St George's Mental Health NHS Trust. In January 22, you became Chief Executive of the South East London Strategic Health Authority. And in November 2003, you worked for the Department of Health, initially as the Director General of Programmes and Performance for the NHS, then as Director General of NHS Commissioning. And in July of 2007, you became Chief Executive of Brighton and Sussex University Hospitals, and then Chief Executive of Public Health England from July of 2012 to August of 2020.
Yes.
Thank you. In her witness statement to the inquiry, Professor Dame Sally Davis has expressed a view that UK public health institutes that deal with infectious disease outbreaks should be professionally led by a clinical scientist. It's right, Mr. Selbie, that you don't hold any medical or scientific qualifications, do you?
No, I don't. And that is unusual for a National Public Health Institute. If I may, I should have said that I'm also the president of IAMFI, which is the international gathering of National Public Health Institutes. It's the world's gathering of the Dame Jennies, if you like, in 115 institutes around the world. And I think I might have been unique in not being clinically or public health qualified.
Do you feel in any way that that hampered you in carrying out your role as Chief Executive of Public Health England?
Well, I've thought deeply about this, and you know, with all the genuine humility, no, I don't think it did, because being a chief executive is not the same thing as being a clinical scientist or an academic. I think it could prove to be a great advantage, potentially, to have that background, but that's not what a chief executive is there to do. And I'm very experienced as a chief executive. I've made lots of good decisions and lots of less good decisions, but I'm definitely very experienced, and that was the basis on which I was appointed. And I've never pretended to be otherwise. And my interview included the chief medical officer at the time, and as you know, it involved bringing together quite a complex set of bodies and to create something new, something that hadn't happened before in this country. So I'll cease there.
All right. Thank you very much for that answer. And indeed, we've been through the extensive experience that you had of acting as a chief executive before taking up that post at Public Health England. But I suspect that you may have been asked a similar question when you gave an interview in 2013 to The Lancet, because asked about your experience in public health, your answer appears to have been, you can fit my public health credentials on a postage stamp. Is that right?
I did say that. It was a bit unkind of them. It was meant to be a light-hearted introduction. And I have had lots of involvement with health inequalities and public health, because in my years as the Director General of Performance, I was instrumental in 6 priorities for the NHS, one of them being health inequalities. It was about the NHS, cardiovascular, cancer, and so on. And then in my Strategic Health Authority days, I had a Director of Public Health for the Strategic Health Authority. And in mental health, it was essentially a public health agenda, yes, which we might talk about. But Professor Marmot, I think, would recognise that if you get it right for mental health, you get it right for the public's health. So it was a little unkind, but if you read the whole of that interview, it was balanced out. And yes, I think the communications director at the time said, I wish you had said that, but it was meant to be light-hearted.
Thank you.
And respectful. It was meant to be respectful about what I didn't know.
Yes. Well, thank you very much for that answer, Mr. Selbie. I know, because I've spoken to you before you took your affirmation and began to give evidence, that you were able to follow the evidence yesterday from Professor Dame Jenny Harris. And so I'm able to take some of my questioning in short fashion with you today. You will have seen that we covered evidence with Dame Jenny yesterday about the rather complex restructuring of public health in England brought about by the Health and Social Care Act of 2012, and the key differences between the HPA and PHE. And so we established the following, that the HPA was an executive non-departmental body and was replaced by PHE, which was an executive agency of the then Department of Health. That PHE brought together, under the management of a single organisation, the previous distinct strands of public health, namely public protection, public health improvement, and healthcare public health. That PHE worked with local authorities who were given new responsibility for improving the health of local populations, that role having been transferred from the PCTs, and that Public Health England also worked with the directors of public health, who for England were employed by local authorities as strategic leaders for public health and health inequalities in local communities. We also looked at the various structural changes over time to the PHE local and regional teams. So I'm going to ask you, Mr. Selbie, if you have any reflections on the impact of all those structural changes, in particular on the following issues. Firstly, the clarity and understanding of EPRR roles and responsibilities. Was there, in your view, any confusion as a result of what I'm going to describe as rather complicated, overlapping and or blurred statutory responsibilities?
So I think initially there was a lot of learning to be done because this was new for local government. Dame Jenny spoke yesterday about that being quite a difficult transition, and I agree with that. But it was about moving, if you like, from a place where directors of public health had been for many, many years to a place where they could make a bigger difference and could have a bigger impact. So I think it was very worthwhile, very brave and courageous of the public health directors to make that shift. But it did bring with it a whole lot of new relationships within councils, with colleagues, as well as with the health sector. And over time, that became some concern, and the Health Select Committee asked us to look at this and to be more assured about these arrangements. And I think I've been reminded of the assurance exercise that we went through in 2016, which was quite positive, but it did involve still a lot of further training and bespoke interventions in different parts of the country. So I think inevitably, because it was a big change, but it was a very worthwhile change. In my heart, I will always say I believe that was the right thing to do, but it did take time, and it did involve a lot of new learning for a lot of people.
In terms of funding, although ministers had promised to ring-fence the public health budget for local authorities, we heard that the public health grant was reduced in real terms by 14% between 2015 and 2021. Were you aware of that at the time?
Yes, it was very disappointing. And, I spoke with the then Secretary of State, Jeremy Hunt, and then obviously with the ministers that were responsible for public health. It was a very disappointing time. In 2015, Mr. Hunt managed to negotiate a lot more money for the NHS, but the Treasury made a condition of that the Department of Health reduced its budget. And there was really only two places that the Department of Health could look for that. One was Health Education England, and of course we needed more doctors and nurses and we had to train more. So it was Public Health England. And I had a conversation with Mr. Hunt where he asked me for 50% of the budget in order to fund the NHS. And obviously that wasn't going to happen because local government were then responsible for essential services like school nursing and addiction services and no smoking clinics and all sorts of things that were terribly important. And of course, but there was a negotiation and the Treasury won that argument, and there was an initial 200 million reduction. I'm afraid that then led to every year after that further reductions. I might add one thing that Dame Jenny didn't come out sufficiently. When this money was originally earmarked for local government, it was essentially only what PCTs had been spending. And there was great variation across the country. And even though we had 3 attempts to try and get a good fix on what was being spent in the NHS, when we eventually settled it, there was a 7-fold difference. We built inequality in from the outset. And the plan was that over time, through growth, we would even that out. And that was what was so terribly disappointing about what happened in 2015, because the ability to even that out was then taken away.
So what was the practical effect of that consistent reduction in budget? How did that manifest itself within public health?
Well, again, Dame Jenny yesterday, and I definitely agree with this, is local government are the most fiscally able of all the public health services. They have managed to manage on less more than anyone else, and they are very good at that. But you're talking very small amounts of money that have huge impacts locally. So £1 million reduction in a year on a budget could mean that they couldn't support a children's centre, or might not be able to continue to offer home support for people with long-term conditions, a whole series of effects. So, you know, the budget, the actual grant of £3 billion or so was a fraction of the spend in the NHS. So any reduction on that was going to have a bigger, have a bigger impact. I think it was just depressing because at that time it was so energising that we had this opportunity at a local level to bring together local knowledge, local leadership with specialist support from Public Health England, lots of expertise to try and do the right thing in a very sort of local way. But you have to fund that if you want to see that happen.
Yes. We've heard of a practice called top slicing, where local authorities would reallocate ring-fenced public health budgets to other services. Do you know, for instance, Mr. Selbie, whether or not pandemic planning or local risk assessments in relation to pandemic planning was one of the areas that was likely to be to suffer from the lack of funding? In other words, were local authorities in the business of taking money that might have been used for those matters and putting it elsewhere to more acute problems?
So there was a lot of concern that local government, under huge financial pressure, would want to use the public health grant. As small as it was enabling of other things. And we instituted an arrangement with the National Audit Office where the use of the grant had to be approved by the Director of Public Health and was signed off by the Director of Public Health as having been appropriately used. This was to try and give some protection to directors of public health against directors of finance or chief executives who wanted to take the money. What I can't tell you is whether that affected EPRR in a significant way. I'd like to think not, because these were very small resources anyway, and they were all involved in local health resilience partnerships where that sort of gap, I think, would become apparent.
All right, thank you. Well, I'm going to return later on in my questioning to the system of subsidiarity and local preparedness. But just touching upon directors of public health, was there a shortage of directors of public health due to retirements and recruitment problems?
It did fluctuate. In the early days, again, Dame Jenny made the point that quite a number of the more experienced, closer to retirement directors of public health took the opportunity to retire at the point of the change. And then there was a cohort of folk that did move over that just didn't find that it worked for them. It was such a different environment to the NHS they'd been used to, and they either went back to the NHS in some role or went on to do something else. And so over time, you saw, we paid a lot of attention as Public Health England to this in training, bringing on professionally developing younger potential future directors of public health. And I think it's all in Dame Jenny's statement about different programmes we put together. We had exactly 152 local authorities. We had about 130 directors because small authorities used to share a director, and that was perfectly normal. So I'm not up to date with the exact numbers, but I do think it was reasonably healthy towards the sort of 2017, 18, 19 years.
Do you agree with the view that the links between NHS staff and public health specialists became fractured, which also affected community infection prevention and control?
Yeah, I think it became more difficult. And one of my greatest regrets was that in strengthening the relationship between public health and Public Health England, but previously HPA and the local government, came at some expense of having removed that capability and that experience from the NHS, not just at PCT level, but at Strategic Health Authority or whatever the management arrangements were at that time. And I was very concerned about that. And in 2018, 2019, reintroduced directors of public health into what was then the 7 leadership teams of the NHS. And there'd been an interregnum of, what would that be, at least 5 years. So I definitely think that we lost our way about the NHS. And they were very, very glad to have this back. Now, what did this mean for infection protection and control? I don't have enough visibility on that. I accept that it was the focus was diminished. That the sort of public health focus on this was, if you like, less. So it was more about what hospitals were doing, because they've always had a big focus on this. I know this to be true. But I think community services very much relied on their when they had their public health responsibilities for this. But I genuinely, you'd have to ask NHS England, I think, because they were actually responsible for this.
The inquiry has heard that some parts of the English public health community have raised concerns about the extent to which Public Health England, as an executive agency of the Department of Health, was able to act as an independent advocate for public health and to set its own strategic priorities. Do you want to say anything about the lack of, or perceived lack of, independence of Public Health England from the government?
Well, I never felt constrained. I mean, there was never a moment when, in fact, there wasn't a single occasion in the 8 years that a politician of any sign required a change to anything that Public Health England produced or published. We did negotiate about timing, and there were issues about, you know, other things going on at the time, but there was never a moment, not one moment, where we were asked to, please don't say that, or can you take that out, or can you redact that? And in a sense, I mean, when you look at the media about Public Health England over the years, I don't think you'd have any doubt about our willingness to speak out. And, you know, the libertarian end of politics in Britain wished we didn't exist. And, you know, they were always complaining about what we were what we were advocating for. So I don't think that. And Dame Jenny spoke yesterday about the particular protection that we had for our scientists and our public health professionals of all different forms, that although part of the civil service, we had a special code approved by the Treasury, because the Civil Service Code doesn't allow civil servants to speak to the media without ministerial authority, and that did not apply to Public Health England. And I was very proud of that. That was one of the early successes, to explain that actually our voice may not have been loud enough at times, or we might not have got it right, and others might have said that, you know, we should have been doing other things or concentrating on other things. But there was never any doubt in my mind that we were, you know, and I would have resigned unquestionably. It was absolutely the heartbeat. We were independent to science and evidence. We were not independent of government, and that is often misunderstood. There's not a national public health agency on the planet that is independent of its government, because you can't separate politics from public health. But independence to science and evidence, definitely.
All right. With such a broad public health remit, how did Public Health England, under your stewardship as Chief Executive, decide which public health strategies to prioritise each year?
So the heart of it was the global burden of disease, which was if you like, the health profile of the country, what was killing people, what was taking people away early in an avoidable way. And then Michael Marmot's work was hugely instrumental about, well, that might be what people are experiencing, but it doesn't tell you much about why or what you can do about it. So we try to balance across health improvement and health protection. You've heard from many that these are inseparable things. You can't have a protected population unless you have a healthy one. And so we set priorities balanced across the wider determinants with the biggest priorities. So, for example, we would tackle tobacco use, and we would tackle obesity. But we also had HIV and TB, the start to life. That was Michael Marmot's biggest advice to me, that we should focus on the beginning of life. So it was a combination of those two sources of the best public health evidence that's available that helped us to make these judgments. And we made those judgments with the Department of Health. You know, we didn't just say and publish them. So we negotiated. We spoke to NHS England. We spoke to partners, the third sector, and of course with ministers and with the chief medical officer. So the priorities were, if you like, agreed priorities, but those were the two sources for how we came about them.
As you know, Matt Hancock gave evidence to the inquiry this morning. Although he wasn't asked about this in evidence, at paragraph 99 of his statement, he talks about the conglomeration of different public health issues within Public Health England. And in his view, it was a mistake to create Public Health England as a body responsible for tackling non-communicable public health like obesity, as well as communicable diseases and preparing for pandemics, because his view is that it was inevitable in those circumstances that the organisation, Public Health England, would spend more attention on tackling issues in front of it rather than worrying about the next pandemic. Do you agree that more attention of Public Health England was spent on tackling non-communicable public health issues rather than pandemic preparedness?
So I've thought a lot about this, of course. I don't believe that. Our first priority, beginning and end, was health protection. That was our raison d'etre. It was what we did. It's 24 hours, 7 days a week, and you've got the data about the thousands and thousands of outbreaks of men and the sort of big events that happened over those years. And Jenny spoke about them, but I would have added others to them as well, that were managed by Public Health England, Health Protection, with partners, but very much with our expertise. At no point, not ever, did we compromise on that. I don't say that with hindsight. I say that with how could I describe it? That was our core purpose. But you cannot keep people safe unless you address the wider determinants. And you've had witness statements. I thought the one from Richard Horton was particularly good about how you can't tackle health protection without tackling health improvement and inequalities. And so there are many different ways in which you can organise to best effect, and different countries approach this in different ways. Some have separation. Most are moving towards integration, but it's not really that. For me, the question is, how do you deploy against the essential health functions set out by Geneva, which include all these different areas, in your context, in the way where you can get the best, like the best from that investment? There's not an answer that says, and it is this. But I do not agree with the prior Secretary of State that you can separate these. You have to find a way of bringing them together. That may be organisationally, or there might be other ways in which that might be done. But you can't, frankly, I'm going on too much.
Mr. Selbie, sorry to interrupt. Could you also try and speak a bit slower? Don't worry, you're not the first witness to speak too quickly. We've all done it. So if you could just try, I know it's difficult, but...
Thank you, Madam.
I'm so sorry. And normally I speak very slowly, so it's just... forgive me, I will try.
I think I may be getting you a little bit animated, Mr. Selbie, so it's probably...
Yes, I shall turn it down.
I want to move on, please, to ask you about Public Health England's responsibilities for preparing for and responding to pandemics, and remind you of what you say at paragraph 46 of your witness statement. You say, in my view, Public Health England carried its emergency health protection work up to the point of January 2020 in the way that it was asked to do by ministers. It is also my view that although Public Health England was not mandated or funded for at-scale pandemic readiness and response, it did deliver on the tasks and responsibilities which were mandated by the Department of Health and Social Care and the Chief Medical Officer throughout the first phases of the COVID-19 pandemic. What did you mean when you said that, in your view, Public Health England was not mandated for at-scale pandemic readiness and response?
So the big gap was mass testing and mass contact tracing, because the flu plan didn't ever envisage that would be necessary. And all the thinking that I know you've explored extensively about MERS and the technical, high consequence infectious disease, none of that was required a mass response. It required what we called in Public Health England a large scale response, but the numbers were in the few hundreds, not what was eventually required. And there had never been any discussion at any point with anyone in my discussions with the Secretary of State, the Chief Medical Officer, before and current, or in any place about the scale of pandemic that we faced. So when I look at the budget for Public Health England, it is 1/4 of 1%. It is actually 0.23 of 1% of the NHS budget. It doesn't even add up to the cost of a small hospital. And for this, we ran amazing. I mean, I don't wish but gold standard science at Portendown and Colindale and our regional laboratories and everything else that we've been speaking about this afternoon. It was just not ever part of the remit. It was never part. It was never part of what we were asked to do. My reflection about and I know it's module 2, is that notwithstanding that, I'm intensely proud of what Public Health England were able to do in those first few months, because everybody had to pull together. And one of the benefits of Public Health England was that we had scale and allowed us to basically draw on everyone to come together. Have I answered your question? Please do come back. I may not have.
I think you have to a certain extent. I want to ask you some questions about the UK influenza pandemic preparedness strategy of 2011, about which I know you will be familiar, because whilst Public Health England may not have had any mandate from the DHSC in relation to mass testing or contact tracing, and indeed there's no provision in that strategy for those levels of preparedness. The inquiry has heard from several witnesses, including Mr. Hancock this morning, that one of the major flaws in that strategy was the doctrine that lay behind it, that it was based on a premise that it would not be possible to halt the pandemic, and that the plan was really a clean-up plan rather than a plan to prevent the spread. Do you agree, firstly, that was a major flaw in the plan, in the strategy?
I'm not really qualified to say about what the doctrine might have been, because I would have looked to medical scientific colleagues to be able to respond to that. What I would say is that, and I agreed with Dame Jenny on this, that it was entirely sensible for the country to have an influenza pandemic plan, even if that's not what we then faced. It would have been negligent not to have had such a plan. And pretty much every country, I think, would agree with that. But I never thought into, well, what happened? How do you prevent that? How do you prevent such a thing happening, and it's definitely for discussion.
All right, but the assumption that lay behind the strategy was that 50% of the population may well be infected. If one takes that assumption, what was Public Health England's responsibility in terms of the assumption that lay behind the strategy? What plans and preparations and assessments was Public Health England expected to do?
So our plan was in the first phases was the detection and the assessment phases. So first of all, I do recognise the numbers. So our responsibility was to know what was coming through the surveillance systems that we had, and then to develop the assay, the test necessary, adapt if necessary, and then roll that out to laboratories, principally in the NHS. Again, something we might want to explore, but in my statement, and I think in Dame Jenny's, about the difference between public health microbiology and diagnostic microbiology, which is often misunderstood. And so our role, in addition to EPRR, of course, and supporting the whole the country with guidance and necessary sort of public health advice, was essentially in, first of all, knowing what was coming towards us, and then being able to get a test out to the NHS so that they could do the diagnostics.
And was Public Health England in a position from 2011, when this strategy was in place, to ensure the capacity for testing up to 50% of the population, if this indeed took place?
No, because you wouldn't. But my understanding is you wouldn't be testing 50% of the population. You would be testing for surveillance and research purposes. You would be testing just to know what was happening, and you would be doing ongoing surveillance to be looking for any changes in the virus.
Yes.
So if emphatically it wasn't what we then faced, but was that clear enough?
Yes, and so is it your evidence, Mr. Selbie, that in terms of the assumptions as set out in the strategy, Public Health England would have been in a position to provide that level of testing if the assumption that was set out in the strategy had come to fruition?
I sincerely believe that.
Do you agree that it was another flaw to the plan, that it only dealt with influenza, and despite there being a line within the strategy suggesting that the plan had to be flexible, that in fact there was no advice as to how that flexibility should be practically employed, and that a better plan would have been a generic respiratory plan?
I do.
All right. Finally, were you aware that during the course of the period of time that passed between 2011 and the onset of the COVID pandemic, that this plan was never updated? Were you aware of that at the time?
No, it didn't really get past my consciousness. I know you heard yesterday about NIAP.
Yes.
Which was and that was constantly updated, and that was, if you like, our agnostic response plan, which by 2016 incorporated CONOPS, which I know you talked about yesterday, and was developed every year, refreshed every year from lessons learned exercises, all sorts of events that had happened. And we had assurance processes that I think were very good, and were then sent up for external assurance to the Department of Health. But the actual flu plan, no. That never, it wasn't conscious on my conscience. No.
Is it right that the All Threats Plan NIAP had been exercised and updated from time to time, but the Pandemic Influenza Response Plan set out in 2014 had not been updated since that was first published, as set out by Dame Jenny yesterday? Do you agree?
Yes, I recognise that. My point is that the NIAP was the operational plan that we could apply and did in many sorts of different scenarios. But the 2014 flu plan, because it reflected the 2011 DH plan, there was, I think, a sense that we would wait until, and then there were various things that happened over those subsequent years, not least Brexit, that I think just kept pushing that back. If I could turn the clock back, and I wish I could on so many fronts, then, you know, obviously we'd have said, well, hold on, that just needs to be, but it would have still been a flu plan. It would have still been a plan that didn't assume what then happened.
Yes. You will be aware that we established yesterday with Dame Jenny that the flu plan was out of date in several respects, not only in relation to the structures within Public Health England, which had changed between 2014 and the onset of COVID, but also the wrong description of the Threats Committee, which itself was abolished by 2019. Are you concerned, Mr. Selbie, that there was in place during your watch an important plan that was not updated in any respect over the 6 years between its inception and the COVID pandemic hitting?
Yes, of course, I'm accountable for that.
All right, thank you. I'd like to move on now to look at some minutes from an oversight meeting which took place in October of 2017. They are at 179643, please. And can we go to the entry at 17126, which I think is at page 5. This is the PHE emergency response and EPRR oversight group. And at 17126, we can see this, that the group discussed the plans and raised several comments regarding the coordination with NHS plans. And it was noted that engagement with NHS England was critical as they would be responsible for the patient pathway. And these were also an issue with private laboratory. There was also an issue with private laboratory testing where PHE is not notified of results. And then if we can go, please, a little further down to 127 and 128, it was queried how the plan fitted in with the work undertaken with the HCID programme. Somebody noted that further discussions with someone else and Mike Jacobs of the NHS are needed urgently to ensure this plan fits with the HCID work, to ensure there is no contradiction in plans. And the meeting agreed the plan could be published as an internal draft to staff with the caveat that the document is interim and not to be shared outside of the organisation. DT to link with GD regarding wording for the draft release of the document to ensure staff are aware of its status. Now, I hope that you were able to follow that, Mr. Selbie. This is a discussion of a group in relation to the MERS plan, wasn't it?
Right, that's what I wanted just to clarify.
Okay. And I want to just explore with you the fact that these notes suggest that as of October 2017, this plan wasn't finalised because there were some outstanding queries about how the plan fitted in with work undertaken by the HCID programme. Are you able to help us with what those concerns were, looking at these notes now?
I'm afraid not. I imagine JH is Jenny Harris, and of course Mike Jacobs was the lead clinician for the HCID centre at the Royal Free, and was very involved. We were all very involved with each other over the Ebola outbreak, and so my sense of what you're saying is that there was a natural. We need to get this together. We need to make sure that it's coordinated, that people, you know, that there's alignment. I believe it did actually work out because we used it in 2018 for the MERS case, and we used it subsequently for other, monkeypox being the one that I can most remember. But I can't remember the detail of at that time what the concern might be. But I'm satisfied, as much as I can be, that they were talking to each other, which is what I would hope for.
Yes. Well, whilst it's laudable, perhaps, that there is an attempt to organise joined-up thinking with the high-consequence infectious disease programme.
Yes.
Our understanding is that, in fact, this plan was never finalised. It remained as an interim plan, and although you suggest that it could have been utilised during the MERS outbreak in 2018, the information that the inquiry has is that these discussions that were expected to be undertaken did not, in fact, lead to the plan being finalised. Does that accord with your recollection of what might have happened?
I regret I don't. I can't say, and what I would be doing would be asking UKHSA if they could clarify that, because I'm surprised by that.
Well, that's what we will do, but I think you've probably answered my next question. If this plan remained as an interim plan and had not been finalised between this discussion in October of 2017 and the onset of the COVID pandemic, that would surprise you, and that would be something which you would not approve of.
I wouldn't approve of that, but I would say that my understanding is that it worked rather well, without, in the sense that we practiced it in 2018 and 2019 through actual lived experience of pathogens that were handled through that pathway. So my surprise is that it wasn't finalised, and yes, I would not be happy that it had not been finalised.
Thank you. I want to turn to ask you some questions now about the HCID programme. This was a network that was established in 2015, 2016, at least in part due to the need for it to be established during Ebola, specialised facilities around the UK where patients with highly infectious or transmissible diseases could be treated. And is it correct, Mr. Selbie, that in the United Kingdom, a high consequence infectious disease is defined according to the following criteria? It's an acute infectious disease that typically has a high case fatality rate, may not have effective treatment, and is often difficult to recognise or detect rapidly, has the ability to spread in the community and within healthcare settings, and requires an enhanced individual, population and system response to ensure it's managed effectively, efficiently and safely.
Yes, I recognise that.
Thank you. Is it right that both SARS and MERS have been defined as HCIDs?
Yes, I believe so.
And it may seem like an obvious question, Mr. Selbie, but why do HCIDs require a different response plan compared to other infectious diseases like influenza?
I think because they are by definition rare, which is one of the criteria, that they are genuinely unusual. And this was one of the great strengths of Portondown and Colindale, is we had specific facilities to be able to quickly know what it is we were dealing with. Quick was really important because, if you had something that was terribly violent, you needed to get the staff properly protected and fast. So these things don't happen that often, but when they do, the thing is to contain them and to manage them. Read across for that what happened with, C19.
All right, thank you. In an annual remit letter from the DHSC to PHE for the year of April 2016 to March 2017, there is this entry: working with government and NHS England to develop a joint programme of work and production of plans for the public health system's response to high consequence infectious disease incidents, expect to be completed in 2017 to 2018 with interim outputs throughout 2016 to 2017. Now, that suggests a clear intention for the system to be in place by 2017, 2018. But the inquiry understands that as of March 2017, that work had not been completed and the system had not been set up. Is that something which you have personal knowledge of?
No, I don't. But may I just quickly say that we had what you called a quarterly accountability meeting with the Department of Health, where we would review progress against all the different elements of the remit letter. Those, of course, on track, those that were ahead and those that were not, and what we were doing about those that were not. So I expect the Department of Health will have a record of that particular matter and what was the story about that at that time. It was Public Health England that asked for an EPRR element to those quarterly accountability reviews because it was such an important part of our work. But can I decline to say, I don't know, I can't say, but I do know who would know, if you like, and that would be the Department of Health.
Thank you. Exercise Broad Street, which took place in January of 2018, was an exercise sponsored by the HCID Programme Board. And in it, PHE and NHS England participated, and an observer from DHSC also attended. It was a discussion-based exercise conducted at PHE Colindale in London to consider the future definitive HCID service in England and the challenges that an HCID incident could present professional partners with. Do you remember that exercise taking place, Mr. Selbie?
Well, only because I've read about it in the evidence pack, but I wasn't personally involved at that time.
You will have read then that one of the concerns raised during the exercise was that the total turnaround time for getting a diagnosis was 24 hours, which was considered to be too long, and the aim was to try and reduce that time to below 6 hours, which would improve the efficiency and cost effectiveness of the service. One of the strongly featured comments was about getting patient samples from the point of sampling to the testing laboratory, and at that time it required a courier service which was neither optimal nor consistent across England. And one delegate, you will have read, was quoted as saying, "We recognised this for years. We need a common courier system that has capacity." A preference was also expressed for near-patient sample testing because multiple sample testing locations could reduce transport time, thereby reducing total diagnostic turnaround times. And it was suggested that transferring samples to PHE Porton may not be optimal due to its geographical location, and that a northern and southern hub would be a more viable option.
Yes.
Dame Jenny Harris told us in her witness statement that the HCID programme was closed in April of 2018. Do you remember the closing of that programme taking place?
I not at that time, but again, I've read the you included in the evidence pack the minute of the meeting that, if you like, recognised that decision. Can I say that I agree with all of that about the need to have probably a small number, but geographically sensible capability around the country so that it wasn't all dependent on getting a sample into Wiltshire. I do know, as you know, that we do have these laboratories in, I'll get it wrong, but Manchester, Bristol, Birmingham, but anyway, and memory tests, but it's 3 or 4 with
4 centres, I think. Yes.
That capability. I'm sure that. I knew about the number, just about where they in Cambridge as well. And I'm very surprised. It would take 24 these days. It would take 24 hours to do anything of that nature.
Well, what I want to ask you about, Mr. Selbie, is what happened to this particular issue, as well as other matters that were raised during the course of the programme about community sampling and diagnostic testing and guidance when the programme was shut down. Who took over those issues, partly raised in this exercise and partly part of the work stream that was created during the course of the HCID programme?
So I'm afraid I can't help with why was the programme closed. Dame Jenny Harris was what we called the SRO, which meant she was responsible for making sure that any actions that flowed from that hadn't been completed was put into what we might call business as usual, be picked up through the EPRR oversight and the delivery team supporting, brought up to and the management team as necessary. I never had any cause for concern or raised with me at any point that there was a need for my intervention. I was content. I mean, I was supported by an exceptional, talented team. I mean, I'm not going to talk through all of them, but of course Jenny was one of them. But I had many Jennies who were professionally at the high, you know. So and they were all very capable of coming to me and saying if they were concerned about an outstanding action or some investment that they needed. No, to my memory, no such concern raised.
Given what we've just seen about concerns raised over the timing of testing, did you, during your stewardship of Public Health England, ever look into contracts with private laboratories to assist with surge testing? No.
We did lots of work through, as you talked yesterday with Dame Jenny about our income that we generated commercially, and you know, providing that was within health protection, you know, what it was like skills and capabilities that we had or wished to develop, then we would work with whoever wanted to work with us, and that would include the private sector. But there was never any discussion in those years about using the private sector in that way.
Do you think that there should have been?
No, not particularly. There was no. There was no. I mean, Public Health England didn't regulate or accredit or in any way constrain the private sector or any academic provider of laboratory science from doing what they wish to do, providing they could meet the standards set by the Health and Safety Executive. So, of course, there's lots of private laboratory work, but it wasn't necessary in that context at that time for public health microbiology. We had sufficient capability, sufficient capacity for what was asked of us. I mean, I love the private sector. They've got so much to offer. They've got so much to give. But in that context, in that setting, it wasn't necessary. It wasn't necessary.
But looking at the PHE pandemic flu strategy of 2014 and the UK pandemic flu strategy of 2011, wasn't it obvious that a huge expansion of testing would have been necessary if that had come to fruition, and that the existing capability that Public Health England had over those years was not sufficiently scalable?
No, that was not my understanding. That if we had had an influenza pandemic, Public Health England was genuinely perfectly capable of doing the detection, assessment, the creation of the test and the rollout of that. The assumption was that the go-to for clinical diagnostics was the NHS. And if you look at healthcare systems around the world, it's the healthcare system that provides the clinical diagnostics, not the public health system. To my knowledge, there is not a public health agency that does clinical diagnostics anywhere in the world. The CDC US, the China CDC, from Pakistan to Ethiopia. That clinical diagnostics is a healthcare responsibility. So there was never any requirement. What public health microbiology does is research, surveillance, and forgive me. But the initial diagnostic of what the pathogen is, and then making sure people know what they need to do. But it is not right that there was ever any assumption that Public Health England would require mass testing capability for the influenza strategy.
I want to...
Sorry, it was reference capability that I was searching for.
Reference capability,
Reference,
thank you.
reference, surveillance and research.
Yes. Moving back, please, to the system of subsidiarity. What were Public Health England's responsibilities so far as local risk assessment and local pandemic planning were concerned?
Well, this was principally through something created. Again, I'll try and be brief. The Local Health Resilience Partnerships created in 2013, which were a creature based on local resilience forums that had proceeded for quite large geographical areas, and they covered the same areas that the police and the fire service and others covered. But there's lots and lots of partners in health, as you have gathered. So the Local Health Resilience Partnership was a way of focalising that at a local level. And that was jointly chaired between a local authority within the area, so Director of Public Health, and NHS England. Public Health England advised, attended where possible, but essentially local risk assessment and the management of and response was through the Local Health Resilience Partnerships. I'm trying to remember my acronyms. And there was a very powerful contribution from Public Health England about expertise and the sharing of sort of good practice and so on. But that was handled locally between the NHS and local government.
So would Public Health England provide expertise to the local resilience forums or the local authorities in terms of their own assessment locally of pandemic risks and that sort of thing?
Yes. And in 2018, we produced, with the Association of Directors of Public Health, good practice guidance jointly for local authorities and the NHS.
Did Public Health England ever assess whether or not the local resilience forums or the local authorities were themselves performing acceptable risk assessments and had in place adequate and responsible plans for a pandemic hitting?
Yes, we did, and we were asked to do that by the Health Select Committee. I mentioned this earlier, and so we were, if you like, detailed by the Department of Health to undertake such an exercise. It was quite sensitive because local government are not national government. They are government in their own right, and they're quite protective of who comes along and audits what it is they're doing. So it took us a short while, but we did agree an exercise with local government and with the NHS, which was completed in 2016. It was anonymised for the purposes of what got published, but everybody got to see their own results. And then there was discussion that went on between the centre or the region of Public Health England, the local area team, or whatever they were called at the time in the NHS, and with local government. That was published by the Health Select Committee, I think in 2018. There was a plan to refresh that assessment in 2020, which then never happened because of COVID.
And did the pandemic preparedness and planning that fell to local authorities include plans for social care?
Yes, well, local government are largely responsible for social care. And so, yes. To the extent that they did, I don't, I can almost imagine what you're going to ask me next.
Well, I'd like to put to you something which Matt Hancock told the inquiry this morning, which was when the pandemic struck, he was told that local authorities were required to have pandemic preparedness plans. And when he asked to see them, his Minister for Social Care found out that there were only 2 local authorities which had reported to have these plans in place, which he considered to be wholly inadequate. I'd just like your reflection on that evidence.
Well, so would I, if that was the actual case. But I've just said, in 2016, we assured that these local health resilience partnerships, all 36 of them had plans that they were assessed against, I think, 13 criteria. I can't tell you if social care was one of them, but they were then, if you like, peer-reviewed, they were externally assured, and they were published and followed through. I think but I didn't listen to the Secretary of State this morning, the former Secretary of State, but I would definitely concur that social care was just not on our radar, and there's no getting away from that.
To what extent did Public Health England engage with other public health agencies in the devolved nations?
Oh, regularly. We had very regular contact. We had networks for health protection. So I had Professor Sir Paul Cosford, who late died of very profoundly senior and much loved Director of Health Protection, and he would coordinate the colleagues in the four nations. We talked about lots of other things. I went personally to Cardiff and Edinburgh and Belfast on quite a regular basis, and we basically cared for each other. There was no we shared openly, and Public Health England was like the mothership for certain capabilities that you wouldn't be able to replicate everywhere. Very available to the four nations.
I want to turn now to ask you about public health resilience and health inequalities. And you've already made reference to Professor Sir Michael Marmot, who, as you probably know, has given evidence to this inquiry together with Professor Claire Bamborough on the issue of health inequalities. The inquiry has also received, as you know, a statement from the Editor-in-Chief of The Lancet, Richard Horton, who talks in his witness statement of the fact that the science that has guided government responses has come mostly from infectious disease specialists and epidemic modellers who understandably frame the health emergency in terms of their two disciplines. But he talks about the fact that what happened with COVID was not really a pandemic, but was twin epidemics clustered together because COVID-19 itself was very challenging, but when you take that into account in terms of the state of the health of the nation, then that made it even more difficult to cope with. Do you agree with that?
I do. He actually used the phrase syndemic.
Syndemic, yes.
And I know my academic qualifications are marginal, but I did publish in the last year with the Deputy Director General of the WHO on this issue. It wasn't a pandemic as such; it was a syndemic for all the reasons that are set out by Michael Marmot. And I said earlier, I was very taken by what Richard Horton had to say, because he's right. You have to take account of all of these if you want to truly make a difference. You can't just say, we'll do something about cardiovascular disease or cancer if you're not doing it for those that are most vulnerable, the people at most risk. So I won't get back onto my, but essentially I completely and utterly agree with that.
Thank you. I'd like to display, please, document 211268, which is a report of the Inquiry Panel on Health Equity for the North of England, chaired by Margaret Whitehead. It's entitled Due North, Report of the Inquiry of Health Equity for the North, and it's dated September of 2014. And if we could look, please, at page 6, which explains why the report was commissioned. It says this: life is not grim up north, but on average, people here get less time to enjoy it. Because of poorer health, many people in the north have shorter lifetimes and longer periods of ill health than in other parts of the country. That health inequalities exist and persist across the north of England is not news, but that does not mean that they are inevitable. While the focus of the inquiry is on the north, it will be of interest to every area and the country as a whole. And then it talks about the fact that the inquiry was commissioned by Public Health England. Do you remember this inquiry being commissioned?
Just pause there, please.
Oh, yes, very,
just sorry,
very
before you
Sorry.
answer, Sorry, forgive me for interrupting. Roughly how long more?
This is my final topic. I do know that permission has been provisionally granted to COVID bereaved Families for Justice to ask about one topic.
I'm wondering if it might be sensible. I gather the stenographer's having a tough time. Not surprised. Given we've got about 5 or 10 minutes left, 5-minute break, or would you longer? Would a 5-minute break be enough? You sure? So remember that question.
I will. Keep it in my mind.
I'll be back in 5 minutes.
Okay.
All right.
Lady. Mr. Selbie, can you see and hear me again?
Yes, I can.
Oh, there's this. I think there's a slight delay between the picture that we have of you and the sound, but I'm going to carry on because I only have so few questions left now. I think it might have caught up now in any event. Could we display page 30, please, of this report, which I hope will show us two maps of the life expectancy amongst males and females by local authority between 2009 and 2012. Females on the left, males on the right, and we can see that the red areas show the lowest life expectancy on both maps, and they are pretty much mirrored one to the other.
Yes.
The actual findings as to the causes of health authorities are at page 74. Can we have a look at that, please? We can see on the left-hand side that the inquiry's overarching assessment of the main causes of the observed problem of health inequalities within and between North and South are differences in poverty, power and resources needed for health, differences in exposure to health-damaging environments such as poorer living and working conditions and unemployment, differences in the chronic disease and disability left by the historical legacy of heavy industry and its decline, and differences in opportunities to enjoy positive health factors and protective conditions that help maintain health, such as good quality early years education, economic and food security, controls over decisions that affect your life, social support, and feeling part of the society in which you live. Now, the inquiry recognises that some of the recommended actions in this report could only be taken forward by central government. But if we look at recommendation 4, which is at page 19, there were specific actions identified for Public Health England. Thank you. To conduct a cumulative assessment of the impact of welfare reforms and cuts to local and national public services, to support local authorities to produce a health inequalities risk mitigation strategy, to help to establish a cross-departmental system of health impact assessment, to support the involvement of health and wellbeing boards and public health teams in the governance of local enterprise partnerships and combined authorities, to contribute to a review of current systems for the central allocation of public resources to local areas, to support the development of a network of health and wellbeing boards across the north of England with a special focus on health equity, and to collaborate on the development of a charter to protect the rights of children. Now, I don't seek to ask you, Mr. Selbie, to deal with each of those recommendations individually, but given that these were present in a report in 2014, are you able, in broad terms, to explain what action Public Health England took to reduce these health inequalities in the north of England after these recommendations were received?
Thank you. This is one of actually a number of reports signed by Public Health England Direct looking at the health of the nation. And the issue about the north is not that it possesses. It's about intensity. There are inequalities everywhere, but the intensity is greater. So I remember very well, it does feel like a long time ago, but that we had regional response because we had the regional director for the north who worked with Margaret and local authorities who had a lot of the influence here with the city, about Andy Burnham in particular for Manchester, but there were other mayors, Liverpool, that we were speaking to about the sort of expert advice and support that Public Health can provide. This is ultimately an issue of resources. We were not able to make the sort of investments happen that would make the biggest difference here. It's evident that these inequalities remain as tough and maybe widening if Professor Marmot is right about this. Public Health England was not in a position to direct resources, but we were in a position to highlight and make transparent, if you like, bring visibility to this, and about the actions that might make the greatest difference. I'm trying very hard not to rumble along, but we did produce all sorts of evidence about what would make the biggest difference for those that were in these circumstances that Margaret Whitehead describes.
Thank you. I think I know the answer to this question, but do you agree with Professors Marmot and Bamborough that over the course of the 10 years preceding the COVID pandemic, that life expectancy, and in particular healthy life expectancy, worsened for those who were living in poverty?
I think that's a very reasonable position.
And so during the life of Public Health England, do you believe that it succeeded in its mission to reduce health inequalities?
Evidently not. But what we did do was, as they make it transparent, bring it into consciousness. We produced evidence, reviews, we gave advice, we tried to get government to focus on the things that would make the biggest difference. We made good progress in certain areas like TB and HIV and Hep C. We made less good progress in areas like childhood obesity, but it wasn't for the want of Public Health England. We made advice available on all sorts of areas that this report speaks to, including air quality and gambling and pretty much everything in between. But in my witness statement, I make the point that politics and public health are inseparable, that you simply can't get these sorts of things addressed without political commitment, not just about money, but about the commitment to do difficult. And difficult is difficult for governments. It's been particularly difficult for this government. And we've seen, so I would say, evidently, inequalities have not improved, and therefore we have not succeeded in our mission. But I would not accept that it wasn't for want of trying and for drawing out the evidence about if you did this, you could expect to see this impact. And finally, people publish things, they say things, they go out and they say what they care about. But these days, I'm not interested in that. I'm interested in show me your budget and then I'll know what you care about. Don't show me your strategy and don't tell me that you care about health improvement in inequalities. Show me your budget and then I'll know whether you do. And I'm afraid that I would say that there has not been a sufficient interest and focus because the spending does not reflect that.
Thank you, Mr. Selbie. My lady, that completes my questioning, and subject to my lady confirming that COVID bereaved Families for Justice do have permission to ask a question around the Chief Nursing Officers meeting of October 2014, then I will hand over to Miss Munro, King's Counsel.
Ms Munro.
Thank you, my lady. The question is, in fact, that was yesterday's question.
I was going to say,
I'm so sorry.
I thought I was having deja vu. That's why I looked over to you.
I was wondering how it was going to...
it's in relation to it.
I'm so sorry.
Don't worry, she didn't mislead me, Miss Munro.
Thank you. Mr. Selbie, can you hear and see me?
Yes, I can, Miss Munro.
Thank you very much. I ask questions on behalf of COVID bereaved Families for Justice throughout the country. It is in relation to a document that you have already been referred to today, the MERS plan. I wonder if we could have that on the screen, please. It's INQ 000179069. Can you see that, Mr. Selbie?
I can, yes.
Ah, that's actually the meeting. It's the document itself. I'm told it's INQ triple zero, 5 zeros.
I can see the document.
You can see the document.
Yes, I can, yes.
Thank you. It's
Yes.
entitled Public Health England Response Plan for Possible, Presumptive and Confirmed MERS Cases. And the purpose of it's a guidance, and the purpose is that it's an internal document to be used by PHE, quote, to inform planning for potential MERS cases.
Yes.
Now, this was from 2017. It's during a period of time of your tenure with PHE. Would you agree, Mr. Selbie, that that particular plan sets out in some considerable detail matters such as infection control guidance and management of both symptomatic and significantly asymptomatic MERS patients and healthcare workers?
Yes.
Would you also agree, Mr. Selbie, that when, and again, we don't need to bring it on the screen because it's a guidance you're familiar with, but for reference purposes, my lady, it's page 14 of the guidance. It includes measures within this guidance that we all became very familiar with during the course of 2020, and they include isolation and self-isolation in the community, contact tracing, communications, and restricting interactions between those affected and the wider public, such as transport restrictions, prohibitions of attendance in public spaces, etc. That's all part and parcel of the guidance, isn't it?
Yes.
Now, appreciating, Mr. Selbie, what you have said this afternoon in answer to questions from Ms Blackwell about this MERS plan, that there needed to be clarification with UK HSA. That notwithstanding, given that COVID-19 was initially classified as an airborne HCID, would you have expected the MERS plan to have been utilised in some form for COVID-19, as it had been for MERS and monkeypox, as you've referenced? And are you able to say whether it was in any form utilised?
Yes and yes. So what you were describing would be regular health protection activity at a scale that we were well used to dealing with. It is my understanding that the HCID pathway was in fact utilised for the early cases of COVID. Yes.
Thank you very much, Mr. Selbie. Thank you, my lady. Those are my questions.
Thank you very much, Ms Monroe.
My lady, that completes the evidence of Mr Selbie and the evidence for today.
Thank you very much, Mr Selbie. I don't know what the time difference is, but I hope we haven't affected your day too disastrously. And thank you very much for your help.
Thank you. Thank you.
10 o'clock tomorrow?
Thank you, my lady.
10 o'clock tomorrow. Thank you.